Conduction velocity. Nerve conduction velocity is directly related to the degree of myelination, Table 9.3. Ions may access the plasma membrane only at the nodes of Ranvier in myelinated nerves because myelin present at the internodes insulates the plasma membrane from being available for ion exchange, and voltage-gated Na** channels are concentrated at the nodes of Ranvier. Action potentials jump from one node to the next, a process called saltatory conduction. Unmyelinated fibers, covered by only one layer of Schwann cell plasma membrane, are essentially uninsulated from the outward movement of excess Na ions, and voltage-gated Na channels are distributed along the entire length of the axonal plasma membrane. The conduction process, known as continuous conduction, is not only slower, but also requires more energy. Somatic motor and autonomic, skeletal muscles receive somatic motor innervation via single efferent neurons whose cell bodies lie within the CNS. Smooth muscles, cardiac muscle, and glands receive autonomic motor innervation via a two-neuron chain where the soma of the first neuron is in the CNS, and the soma of the second neuron is located in an autonomic ganglion in the pons. The somatic motor nervous system, Fig 9.12, is composed of spinal motor nerves from the ventral horn of the spinal cord and cranial motor nerves serving skeletal muscles from motor nuclei of certain cranial nerves. As spinal motor nerves leave the CNS, they travel in spinal nerves to the muscle and synapse at the motor end plate. Cranial nerves leave the cranial vault and pass via branches of a cranial nerve to synapse on the motor end plate of the skeletal muscle. The autonomic nervous system is an involuntary motor stem serving smooth muscle, cardiac muscle, and glands. In contrast to the somatic motor stem, the autonomic nervous system requires two neurons to reach the effector organs. The first motoneuron in the chain, the preganglionic neuron, originates in the CNS, and its axon seeks an autonomic ganglion located outside the CNS, where it synapses on multipolar cell bodies of postganglionic neurons located within the ganglion. Axons of the postganglionic neurons exit the ganglion and terminate on an effector organ, smooth muscle, cardiac muscle, or gland. Postganglionic synapses on the effector organs are more generalized than that of the somatic motor system because the neurotransmitter spreads out over a wider area with a more extensive effect. Additionally, muscles activated to contract may convey the stimulation to adjacent muscles via gap junctions. Somatic motor and autonomic nervous systems, autonomic innervation is subdivided into two functionally different divisions, the sympathetic nervous system and the parasympathetic nervous system. Broadly defined, the sympathetic system is regarded to be vasoconstrictor in function, whereas the parasympathetic system is regarded to be secretomotor in function. The sympathetic nervous system functionally prepares the body for right or ait by slowing down visceral activity, dilating the pupils, increasing blood pressure, heart rate, and respiration, and increasing blood flow to skeletal muscles, Fig 9.13. The parasympathetic nervous system functionally prepares the body for rest and digest by increasing visceral functions, constricting the pupils, decreasing blood pressure, heart rate, and respiration, and decreasing blood flow to skeletal muscles, see Fig 9.13. The neurotransmitter between the preganglionic and postganglionic neurons in the sympathetic and parasympathetic nervous systems is acetylcholine, and acetylcholine is the neurotransmitter between the postganglionic neuron and the effector organ in the parasympathetic nervous system. Norepinephrine is the neurotransmitter between the postganglionic neuron and the effector organ in the sympathetic nervous system. An accumulation of nerve cell bodies located outside the CNS with the same general function is known as a ganglion, see Fig 9.13. Two categories of ganglia exist. Sensory ganglia are associated with all of the sensory nerves originating from the spinal cord and with cranial nerves V, 7, 9, and X. Sensory ganglia associated with the spinal cord are called dorsal root ganglia, whereas sensory ganglia associated with the cranial nerves are identified by specific names related to the nerve. Sensory ganglia contain unipolar neurons. The endoneurium of the axon becomes continuous with the connective tissue surrounding the ganglion. Specialized receptors surrounding the terminals of peripheral nerves are able to transduce the various stimuli, initiating an action potential, which is passed directly to the brain or spinal cord for processing. Autonomic ganglia are associated with purely motor function. Preganglionic cell bodies of parasympathetic neurons are located in the brain and sacral spinal cord, whereas cell bodies of the sympathetic neurons are located in certain segments of the thoracic and lumbar spinal cord. The axons of the preganglionic motoneurons seek their ganglia where they synapse on postganglionic motor cell bodies. Axons of postganglionic neurons may rejoin the peripheral nerve of their origin to reach their effector organs. Many postganglionic parasympathetic fibers located in the head, on exiting the ganglia, join branches of the trigeminal nerve, CNV, for distribution to effector organs. Postganglionic parasympathetic neurons arising from Meissner's or Auerbach's plexus located within the gut wall simply synapse on effector organs that lie in close proximity. Sympathetic ganglia are confined to the sympathetic chain ganglia along the spinal column or to the collateral ganglia located along the abdominal aorta. Parasympathetic ganglia associated with cranial nerves are located within the head, except for ganglia belonging to CNX, whereas parasympathetic ganglia associated with sacral nerves are located in the organ that they serve. The brain and spinal cord are composed of white matter, which consists mostly of myelinated nerve fibers along with some unmyelinated fibers and neuroglial cells. The abundant myelin covering the axons gives it the white color. Gray matter, which consists of accumulations of neuronal cell bodies and their dendrites along with unmyelinated axons. The gray color indicates the absence of myelin. The twisted, intertwined collection of axons, dendrites, and processes of neuroglial cells composes the neuropil. Localized collections of nerve bodies in the white matter are known as nuclei. Within the brain, gray matter is located on the periphery, whereas white matter is located deeper. In the spinal cord, gray matter is located deep to the white matter. In cross-section of the spinal cord, the gray matter forms the letter H, and in its center is the central canal, a small foramen lined with ependymal cells that contain CSF. Central processes of sensory neurons terminate on interneuron cell bodies in the dorsal horns. The superior aspects of the vertical bars of the H interneuron axons terminate on motoneuron cell bodies in the inferior vertical bars of the H, the ventral horns. Axons of the motoneurons exit the spinal cord by passing out the ventral roots. Meninges. The meninges represent the three connective tissue coverings of the brain and spinal cord identified as the outer layer, the Dura Mater, an intermediate arachnoid, and the innermost layer, the Pia Mater, Fig. S.14, Dura Mater, the outermost layer of the meninges, is different in the brain than in the spinal cord. The cranial Dura Mater is composed of dense connective tissue consisting of two separate components, an outer periosteal layer closely adhered to the bony cranium, serving also as the periosteum of the inner aspect of the skull. It is highly vascularized and contains osteoprogenitor cells, fibroblasts, and bundles of type I collagen. The innermost layer of the dura, the meningeal layer, which presents dark staining fibroblasts possessing long processes, fine collagen fibers organized in sheets, and is vascularized by small arteries. The innermost region of the meningeal layer, the border cell layer, consists of a thin layer of fibroblasts enveloped by an unstructured extracellular matrix lacking collagen fibers that extends into the meningeal layer. The spinal Dura Mater is not represented in layers because it does not adhere to the vertebral canal as a periosteal layer. Rather, the spinal Dura Mater forms a complete tube surrounding the spinal cord beginning at the foramen magnum and ending at the second sacral segment. Along this tract, spinal nerves pierce the spinal dura, and the space between the bony vertebral canal and the dura, the epidural space, is filled with epidural fat and a venous plexus. 2. The avascular arachnid consist of two layers, one is flat sheet-like that lies against the dura mater, the second layer is formed of sparse, loosely organized modified fibroblasts, arachnoid trabecular cells, interspersed with a few fibers of collagen and some elastic fibers from trabeculae that contact the pia mater. The space between the flat sheet contacting the dura and the trabeculae contacting the pia is known as the subarachnoid space. Blood vessels course through the arachnoid as they progress from the dura on their way to the pia mater, but they are isolated from the arachnoid and from the subarachnoid space by a sheet of fibroblasts derived from the arachnoid. The subarachnoid space is a real space filled with CSF, but the subdural space, located between the dura and the sheet-like layer of the arachnoid that contacts the dura, is only a potential space. Specialized regions of the arachnoid, known as arachnoid villi, extend into the dural venous sinuses and translocate CSF from the subarachnoid space into these dural sinuses. The innermost layer of the meninges, the pia mater, is composed of flattened fibroblasts, mast cells, macrophages, and lymphocytes, and is described as being closely apposed to the brain and spinal cord. The pia is separated from the actual brain tissue, however, by a thin membrane composed of neuroglial processes that adhere to the thin reticular and elastic fibers of the pia and form a physical barrier at the periphery of the CNS. A sheath of pial cells covers the rich vascular supply of the pia, which is replaced by neuroglial cells as these vessels penetrate the nervous tissue. Tumors of the meninges, known as meningiomas, are most often slow-growing and benign. They produce possibly serious clinical manifestations, however, such as brain compression or increasing intracranial pressure. Meningitis, an inflammation of the meninges, may be caused by bacteria or by viruses that have gained access to the CSF. Viral meningitis is not very dangerous, however, bacterial meningitis is not only a very hazardous condition, but it is also highly contagious. The pathogen may gain initial entry through the nose, ear, or throat, and can be spread by the exchange of respiratory secretions via coughing and kissing. The onset of meningitis is characterized by fever, stiff neck, nausea, and vomiting. Meningitis is diagnosed by the examination of the CSF obtained by lumbar puncture, and an antibiotic regimen is used to treat the disease. Vaccines are now available for protecting against some of the common bacteria that cause meningitis. The blood-brain barrier, BBB, is exceedingly discriminating in permitting passage of substances from the bloodstream into the CNS. It prevents most therapeutic drugs, many antibiotics, toxins, and certain neurotransmitters including dopamine from entering the neural tissue. Perfusion of a hypertonic solution of mannitol may alter the tight junctions of the BBB sufficiently for a short time, permitting the passage of therapeutic drugs. Another method of bypassing the BBB is the binding of the therapeutic drug to antibodies against transferrin receptors located in the endothelial cells of the capillaries, facilitating their transport into the CNS. Certain diseases or conditions that affect the CNS, such as stroke, tumors, and infections, alter the BBB by reducing its functionality and permitting the entry of toxic substances and unwanted metabolites into the neural tissue. The subarachnoid space is a real space filled with CSF, but the subdural space, located between the dura and the sheet-like layer of the arachnoid that contacts the dura, is only a potential space. It may become a real space after injury, however, when bleeding forces the two layers apart. This condition is called a subdural hemorrhage. Blood-brain barrier, endothelial cells of the continuous capillaries located in neural tissues form tight junctions with each other, establishing the blood-brain barrier, BBB, which limits the ability of blood-borne material to enter the confines of the CNS. Certain molecules, such as water, and small lipids, can easily pass through the BBB. Most other substances, such as glucose, nucleosides, and amino acids, have to be transported by carrier proteins and ion channels that are specific for them. Still other materials pass through this barrier by the use of receptor-mediated transport. The BBB is reinforced by astrocytes whose processes form end feet that completely surround the basal lamina of the capillaries located in the CNS. The cylindrical sheath fashioned by these end feet form the perivascular glia limitans. Astrocytes also function in transporting metabolites from the capillaries to the neurons and in scavenging K-ions and neurotransmitters from the extracellular spaces surrounding the neurons and their processes. Choroid Plexus. The choroid plexus, composed of tufts of highly vascularized pia mater surrounded by cuboidal ependymal cells, project into the ventricles of the brain and produce approximately 50% of the CSF. It is unknown where in the brain the remaining half of the CSF is produced. CSF fills the ventricles of the brain, the central canal of the spinal cord, and the subarachnoid spaces. Cerebrospinal fluid, the CSF is a clear, protein-poor but electrolyte-rich fluid that has a scant amount of lymphocytes and other cells, Table 9.4. Because CSF is formed on a continuous basis of 0.2 to 0.6 ml/min and is transferred into the dural venous sinuses by the arachnoid villi at the same rate, its formation and resorption acts as a pump that facilitates its circulation through the ventricles of the brain, central canal of the spinal cord, and subarachnoid spaces. This fluid functions in supporting the metabolic activities of the CNS, and by acting as a shock absorber diminishes sudden forces that may act on the brain and spinal cord. Cerebral cortex, the cerebrum consists of two hemispheres whose periphery is composed of gray matter, the cerebral cortex, which overlays the thick layer of white matter located deeper within the cerebrum. The cerebral cortex is folded into elevated areas called gyri that are separated from each other by depressions called sulci. The cerebrum has a plethora of functions, including memory, learning, integration of sensory input, analysis of information, initiation of motor response, and thought processing. The cerebral cortex is composed of 6 horizontally arranged layers. The neurons in each layer possess distinct morphologic characteristics specific to that layer, Table 9.5. The outermost layer lies just deep to the overlying pia mater, and the 6th layer contacts the white matter of the cerebral cortex. All of them contain specific neurons and neuroglia. Because CSF is produced in a continuous fashion, blockage of the ventricles or less than optimal functioning of the arachnoid villi results in enlargement of the ventricles, a condition known as hydrocephalus. This disorder has severe consequences because the excess CSF in the enlarged ventricles exerts pressure on the brain. Because the fontanelles and the bony sutures in the skull are not yet fused in fetuses and neonates, this condition results in enlargement of the head, mental impairment, malfunctioning muscles, and eventual death without treatment. Alzheimer's disease, the most common neurodegenerative disease, affecting about 5 million individuals in the United States, results in dementia that is progressive and terminal. It is usually diagnosed in individuals older than 65 years, although the onset may have occurred years earlier. The most common early symptom is memory loss followed by confusion, irritability, aggression, and mood swings. Later symptoms include breakdown of language, long-term memory loss, decline of senses, general withdrawal, loss of bodily functions, and finally death. Although the cause is not clearly understood, it is characterized by the loss of neurons and synapses mainly within the cerebral cortex followed by gross atrophy of the individual cerebral lobes. Autopsies have shown that patients with Alzheimer's disease develop amyloid plaques and neurofibrillary tangles within the brain that, as they continue to expand, involve a greater number of neurons, rendering them non-functional. Cerebellar cortex cell, the cerebellum comprises 2 lateral hemispheres and a central, connecting portion, known as the vermis. The peripheral layer of the cerebellum, the cerebellar cortex, is composed of gray matter that overlays the deeper white matter. The cerebellar cortex is responsible for maintaining balance during all phases of posture and coordinates voluntary muscle activity and muscle tone. The cerebellar cortex has 3 separate layers: molecular layer composed mainly of dendrites of Purkinje cells and unmyelinated axons from the granular layer, and some stellate cells and basket cells. Purkinje cell layer composed of large Purkinje cells, unique to the cerebellum, whose arborized dendrites are observed in the molecular layer, whereas their myelinated axons project into the white matter granular layer composed of crowded nuclei of small granule cells and glomeruli. Cerebellar islands, representing synapses between axons entering the cerebellum and the resident granule cells. Purkinje cells have only an inhibitory output, and they process and integrate simultaneous information from hundreds of thousands of excitatory and inhibitory synapses before forming a response. Purkinje cells release only GABA as their neurotransmitter substance, and they are the only cells of the cerebellum whose processes and responses extend outside the cerebellum. Nerve regeneration. Although there is some evidence that certain neurons may undergo proliferation, it is generally believed that most neurons and nerves within the CNS that have been destroyed by trauma cannot regenerate because they do not undergo proliferation. Damage to neurons and their processes within the CNS is permanent. Peripheral nerves that have been damaged are able to repair the damage, however, via a series of events known as the axon reaction, Fig 9.15. Axon reaction. Reaction to the damage involves changes in three specific areas of the neuron: local changes, anterograde changes, and retrograde changes. Although some of the reactions to the damage occur quickly, most of the changes, repair, regeneration, and restoration of function take weeks to months to complete. Local reaction occurs at the site of the injury. If the axon is severed, the cut ends draw back from each other, and the axolemma covers the cut ends, diminishing the escape of axoplasm. Macrophages and fibroblasts invade the site of injury and release signaling molecules. The macrophages, aided by Schwann cells, begin to phagocytose the damaged tissue. Anterograde reaction involves the degeneration that occurs to the part of the axon that is between the site of the injury and the end feet. Within 7 days of the injury, the end foot becomes swollen, and as it begins to degenerate, it loses its contact with the postsynaptic membrane. The remains of the end foot become phagocytosed by the proliferating Schwann cells that migrate into the region of the former synapse. The region of the axon and its myelin sheath, located between the injury site and the former synaptic cleft, become fragmented, a process known as Walirian degeneration. Schwann cells cease to form myelin, and instead begin to phagocytose the remnants of the distal axon and its myelin sheath. The basal lamina of the endoneurium remains intact. Schwann cells continue to reproduce, and the newly produced cells form a Schwann tube enveloped by the endoneurially derived basal lamina. Retrograde reaction and regeneration involves the portion of the neuron located between the site of injury and the soma within the CNS. The injured neuron undergoes chromatolysis, its slow bodies diffuse, its nucleus shifts location, its soma enlarges, and the neuron manufactures macromolecules that are used for the regeneration of the damaged axon. The proximal axon end begins to develop numerous axon sprouts, one of which finds the endoneurium to travel down the lumen of the Schwann tube. The other axon sprouts degenerate, and their remnants are phagocytosed by macrophages and Schwann cells. The axon sprout lengthens within the Schwann tube, guided and promoted by factors produced by the Schwann cells, fibroblasts, and macrophages. Growing at 3 to 4 mm per day, the axon sprout reaches the postsynaptic membrane and re-establishes synaptic contact. If the Schwann tube is blocked by scar tissue, and the growing axon cannot penetrate its lumen, regeneration most likely would not occur. Consequently, the postsynaptic cell also atrophies in a development known as transneuronal degeneration, indicating that the neuron exerts a trophic influence on the cell with which it synapses. Until more recently, it was thought that regeneration within the CNS was impossible for many reasons, including the presence of macrophages called microglia, which phagocytose injured cells very quickly, and the cleared space is rapidly filled with a mass of glial cells forming a glial scar. There are neuronal stem cells in the CNS that may be stimulated to proliferate, however, giving rise to new neurons that assume the functions of the cells that were lost because of injury. More recent investigations involving stem cells, neuronal plasticity, nerve growth factor, nerve growth inhibitors, and neurotrophins offer hope of repairing and reversing the results of spinal cord injuries.